fine, Laura. Thanks for that. So hello, everyone. So my name's Craig, and I'm the Pulmonary Rehab Lead in Northumbria Trust. So just to quickly introduce myself, so I've worked as a respiratory physio for the last 7 or 8 years, but over the last 12 months transitioned into a static kind of pulmonary rehab lead role. So what we're going to be discussing today is pulmonary rehab, and hopefully it'll give us as GP practice nurses more information and more knowledge about what it actually is that we're referring patients into, but also just to ensure that we're getting accurate and adequate referrals. So if you just want to, next slide, Laura. So just a brief kind of outline of what we're going to be discussing today. So initially, we'll just very briefly touch over the evidence base of pulmonary rehab. We'll then move on to the structure, so the more nitty-gritty of what it is, kind of the practical element of it as well. Well, then probably the most important part of today's session will be to discuss the referral process and the criteria. So we'll just mention how we now refer to pulmonary rehab, because that's changed over the last 12 months, and also the kind of inclusion but also the exclusion criteria for the exercise program as well. We'll then move on to the outcomes for pulmonary rehab. So we've managed to have a little look at over the last 12 months our outcomes specific to Northumbria. So it'll give you guys a good chance to see, does pulmonary rehab work for your patients when you refer them? We'll very briefly touch upon remote-based pulmonary rehab. So this is around virtual exercise classes, home-based programs, and kind of supported self-management. And then eventually I'll just kind of briefly touch on future plans. So yes, Laura, next slide. So this is just a definition of pulmonary rehab, and this is from the NICE COPD guidelines. So I'll just read this one. So pulmonary rehabilitation, or PR, can be defined as an interdisciplinary program of care for patients with chronic respiratory impairment that is individually tailored and designed to optimize each patient's physical and social performance and autonomy. Programs comprise individualized exercise programs and education. So just to quickly touch on that, so what we want to do with our patients from the first time we meet them, we want patients to obtain the knowledge and the practical hints and tips so that they're able to continue exercising, have more knowledge around the condition and understand how to manage aspects of the condition. So we don't want patients to come for 6 weeks of pulmonary rehab just because the physios advised them to, because eventually what will happen, I think, when they've been discharged from us, they're likely just going to fall back into old habits. So it's really important that they feel like they're empowered during the program, and that's what we try and do from the first appointment, really. You want to move on, Laura? So just a little bit about the evidence base. So normally in physio, there's a lot of treatments that the evidence base is pretty grey around. There's not fantastic evidence for a lot of physio treatments. Pulmonary rehab, there's really, really good evidence that it works. So for the patient, so for your stable patients who might come in for the annual review to the GP, they can improve exercise capacity, dyspnea, health status, and psychological well-being in stable COPD patients. It's not just stable patients who would benefit from pulmonary rehab, also patients who have been admitted of COPD. The same benefits can be seen for those patients as well as the stable ones. And although the majority of the evidence is around COPD, because that's certainly the most common respiratory condition that we see in pulmonary rehab, there has also been a kind of fairly recent influx with regards to respiratory conditions such as bronchiectasis, ILD, and asthma patients. And the evidence base for that shows that pulmonary rehab demonstrates improvements in exercise capacity, dyspnea, and health status as well. So all in all, for the patient, it's really beneficial. I haven't got this. There was a recent study that was done, and I think it advised that pulmonary rehab can improve health-related quality of life just as much as inhalers and medications would do for patients. So I think previously pulmonary rehab was always thought to be a bit of an adjunct to those things, but now it should be kind of deemed as a cornerstone of treatment for those with a respiratory condition. because the evidence is so good for it. If we just move on, Laura. So we've talked about the benefits to the patient. There's also benefits to the healthcare providers. So the NACAP audit is basically one that we're involved in with Pulmonary Rehab, and this is where a lot of services across the UK provide real life data into the world of pulmonary rehab, and it lets every service know, and as a nation, how we're doing with regards to what we're doing really well, but also what improvements need to be made. Now, so far, the general statements have been made from the evidence. So pulmonary rehab can help to reduce hospital admissions for patients. It can also, if patients have completed pulmonary rehab 180 days before being admitted to hospital, then they spend about half the time in hospital than the patients who haven't completed it. So reduced inpatient hospital days. It also reduces readmissions. So for patients who've already been admitted to hospital, their risk of being readmitted is lower if they perform pulmonary rehab. And just on that, every patient who's admitted to hospital with an exacerbation of lung disease, they'll also be screened by a physio on the ward, and then they would also be referred to us from there. Also, it reduces the number of home visits, and it's deemed to be a highly cost-effective treatment. So not only are we seeing benefits for the patient, but we're also seeing a lot of benefits for healthcare providers as well. Just want to move on, Laura. So this was a bit of a hypothetical study. So this was done by the Chartered Society of Physiotherapy, and this is known as the PRIME study. So this basically shows if every eligible COPD patient in England was to attend physiotherapy-led pulmonary rehab, then the benefits would likely be the following. So it would likely reduce exacerbations by 33%, and that would equate to freeing up hospital bed days, so over 106,500. It would also to 151,000 fewer exacerbations in the community, and that would obviously be freeing up GP appointments. And it would also help to prevent 26,600 hospital admissions. So again, pretty big numbers. Like I say, this one was kind of a hypothetical study based off a smaller study beforehand, but it just goes to show the benefits of pulmonary rehab are there if we can refer the patients. So that was just a little bit around the evidence base. So kind of just thinking about exactly what pulmonary rehab is. So we'll probably all have a different knowledge of what pulmonary rehab is. So essentially the BTS, or the British Thoracic Society, they provide kind of the gold standard of what pulmonary rehab should look like. And they advise that there should be a minimum of 6 weeks. So we would always tell our patients it is a commitment. 6 weeks, it is a commitment, and they need to be committed to achieving it. Now, during the 6 weeks, that would consist of exercise sessions and education sessions. So if we talk about the exercise part first, so patients would come to a venue, twice a week to perform supervised exercise sessions. Now, during the first 2 weeks of the program, these patients are likely going to be really stiff and sore because they're not used to this kind of intensity. However, after the first 2 weeks, we then recommend and we'll speak to the patient about performing a third unsupervised exercise session at home. So they'll actually end up doing 3 sessions a week from like week 2 onwards of the program. But for the first 2 weeks, it would just be 2 supervised sessions in a setting. Exercise sessions themselves, so they'll last for 60 minutes. That includes your warm up, your cool down, and a little bit of rest in between each exercise. So they're probably exercising continuously for between about 42 to 45 minutes, I would say, in a session. And the exercises would include both aerobic, so kind of cardiovascular system exercises, and also resistance exercise. Essentially, what we want to do with these patients is we don't directly affect what's happened within the lung during pulmonary rehab. Unfortunately, the damage that things like smoking have done. We can't reverse that. But what we do is we basically look to make muscles, and in particular the leg muscles, the big quad muscles, we look to make them more efficient at getting oxygen in and also much stronger. And those benefits over time will allow the patient to walk further and to do more and have a better quality of life. So that's how we actually improve our patients when they come to our sessions. We also have an education component as well as an exercise component. The exercise component is 6 weeks, so it's a drop in the water really for these patients. Hopefully what we're trying to see with the exercise, if these patients can walk further on their assessment after the 6 weeks, then that should give them more encouragement and motivation to continue doing that because they know that it works. The education is more around the long-term management of the condition. Obviously, these patients have to live with this condition for the rest of their lives. So what we try and do is we want to give them as much knowledge as possible about their condition, but we also want to be giving them some practical hints and tips about topics such as how to manage the breathlessness, how to clear phlegm out of the lungs, what are the signs and symptoms of a flare-up, and what to do if they feel like they're getting one. So the MDT education in Northumbria, we have quite a few physio talks because obviously it is a physio-led service. We also have a talk from the pharmacists who would discuss with the patient's inhaler technique, the different inhalers that they may be on and what that would mean, and also medications such as carbamazepine, elucin phlegm, etc. We also have a psychologist who comes in, and the psychologist is looking mainly around anxiety and mood in relation to having a long-term condition. I think respiratory patients, and you guys will know this as well, are more likely to feel anxious because obviously they would experience breathlessness on a daily basis. So it's just about giving them some coping strategies to manage with that. And then what we'd also do is we have an exercise specialist who would have a good knowledge of exercises in the community and different venues in the community that we can then refer patients onto after the 6 weeks. Because what we don't want to do is improve someone's level of fitness and then give them no more support when they're out in the community. So we'll create with the patient kind of a written discharge plan, and they'll know exactly what they're going to be doing going forward to continue the level of activity. But we can refer to a lot of different services in the community as well. So currently, with regards to Pulmonary Rehab in Northumbria Trust, we have venues at North Tyneside Hospital, we have Howden Community Hub in Wallsend, we have Waves Leisure Centre in Whitley Bay, we have Wansbeck General Hospital, we have Hexham Hospital, and we have Alnwick Hospital. Berwick at the moment is a bit of a starting point because obviously the new hospital is being built, but we have got quite a demand for pulmonary rehab Berwick, so we are hoping to speak to different venues in that area about providing a cohort, so a 6-week course where we can get patients seen in pulmonary rehab there. But that at the moment is kind of the face-to-face venues that we have across Northumbria Trust. Laura, am I right in thinking that this is Northumberland?
Yes.
Yes.
And there might be some North Tyneside nurses as well, but again, it will be the same trust. So.
Yeah. Okay. Yeah. So within Wansbeck, so we have quite a big venue at Wansbeck. So we have up to 12 patients within a class. Hexham and Alnwick are slightly smaller venues, so they're about 7 patients in a class. And again, Berwick, if we get the venue that we're hoping to, we would probably be aiming for between 12 and 14 patients in a class as well. Okay. Yeah, Laura, if you want to move on. So just specifically looking at exercise intensity and how we measure and prescribe exercise intensity in pulmonary rehab. So our patients, first and foremost, are encouraged to work hard in pulmonary rehab. So we do always advise patients as soon as we see them on the first kind of one-to-one appointment, we'll advise them that it's completely normal to be breathless when they come into our exercise sessions, and that's something that we encourage. We do have a scale that patients become very familiar with, and that's on the slide following this one, so we'll talk about that after. But yeah, so we do expect patients to be breathless because they are exercising. Now, when they're doing aerobic exercise, so the aerobic exercises that we perform would be getting on an exercise bike and also either walking lengths of the venue or going on a treadmill. They're the two kind of core aerobic exercises that we achieve. We want patients to be working at about 60 to 80% of their VO2 peak. So that's a pretty intense level for patients. The way that we individualize the exercise prescription for patients is before coming in for the 6 weeks of exercise, they would come into what we call a pre-assessment appointment, and we would do a 6-minute walk test with them. And we would then prescribe their speed on the treadmill in particular, or how many lengths they're supposed to achieve during the session off what they've achieved as their distance on the 6-minute walk test. So that's how we can say that we are individually prescribing exercise for all of our patients, because they would all start with a different speed on the treadmill, if they've had a different, if they've walked a different distance, sorry, on the 6-minute walk test. So when we're talking about the resistance exercise, so we have kind of 2 core resistance exercises. We are going to be introducing a third one, which is going to be leg extensions. But at the moment, we are doing bicep curls and we are also doing upright row, which are both resistance exercises with our patients. Now, what we do is we want patients, again, to be achieving 70 to 80% of their 1 rep max. Now, a lot of services do an actual 1 rep max when they assess their strength for patients, but I think we tend to get fairly frail elderly patients, as you can imagine. So we always don't feel like performing a 1 rep max is really safe for those patients. So we've kind of created what we call a multi-rep assessment, where we can get an estimated 1 rep max off the multi-rep assessment, which is where patients would be asked to lift a weight 10 times to fatigue, basically. So they should feel after lifting 10 that the fatigue need to pop that weight down. So again, that's just how we individualize the exercise for our patients. So when patients come to us, the way that the exercise works, it's a bit of a circuit-based session. So every time they would come in, we would give them 7 exercises to do. And we do each exercise for 6 minutes. But again, we'll always advise patients, if they feel they need to have a rest in between that 6 minutes, that's okay. It's all individual, just based on their symptoms. But they'll do 6 minutes and then they'll have a 1 minute dedicated rest before moving on to the next exercise. To try and make it a bit less tedious for patients, we obviously try and mix up the order that they do the exercises, so they don't come in and do the same exercise every time. We'll reorder the exercises just to keep it a bit more fresh for the patients. But you can see the exercises that we do. So the exercise bike and the treadmill or the shuttle walks we've already discussed. They're the 2 cardiovascular or aerobic exercises. Bicep curls and upright row are the 2 resistance exercises. And then we kind of have a range of functional kind of lower limb exercises. So that would include things like sit to stands, it would include squats, and it would include the step ups that we do as well. Yes, they are aerobic exercises, but it's also strengthening the lower limbs as well. The reason we do a lot of leg exercises is because obviously the lower limbs are bigger muscles, and if we can improve the muscle function on these muscles, then we're going to get overall greater improvements in the breathing. So it's a catch-22, because normally patients find those exercises more difficult, which they will be, but after time, it gives the patients greater improvements going forward. Yeah, Laura, if you want to move on. So this is the scale that patients will be familiar with when they come to Pulmonary Rehab. Now, we show patients this scale on their pre-assessment appointment before actually starting the exercise sessions, just to introduce it to them so that they get a feel for it. But essentially, it's the modified Borg breathlessness scale, and it goes from 0 to 10. So what we want for our patients within Pulmonary Rehab is we want them to be exercising to a level of 3, 4, or 5 on this scale. So when we read through them, we can see the little explanation underneath. So we always say to patients, you should feel like you are breathing heavier when you come to do exercise with us. So you'll be breathing deeper, you'll be breathing faster, your heart rate will go up, you'll certainly start to feel warmer. Your legs, more than likely, towards the end of a session will start to feel a lot heavier. The key kind of way for patients to know that they're exercising at the right level versus too little or too hard is by their speech. So we always say to patients, you should still be able to talk, but it should be very kind of broken sentences, in the sense of you can say a couple of words and then you might need a breath, a couple more words, then need a breath. If patients are talking like I'm talking now, unfortunately, we're not working hard enough to get the benefits to the muscles that we want to achieve. If patients were exercising kind of at a 6 downwards on this scale, yes, they would still be improving their muscle function, but as we're probably aware, when we've exercised to a maximal kind of capacity, it feels really, really horrendous. It doesn't feel comfortable at all. And by exercising to that level, you actually find that you need a lot more rest afterwards. So all in all, the patients are going to get actually less work done by exercising at a more severe level. Okay, but that was just to kind of touch on how patients become familiar with, and then patients would then own this breathlessness scale during the sessions, so that when they finish the program, they still know what the right level of exercise intensity would feel like. Yeah, Laura, if you want to move on. So just going towards the referral process and the criteria. So the NHS 5-year plan, which I think this is a few years ago now, but I think they'd found that there was only 13% of eligible COPD patients were being referred for pulmonary rehab, and they wanted to try and increase that to at least 60% by kind of last year. I don't think we're quite at that level at the moment, but I think we've definitely noticed in our trust we are getting a greater uptake of referrals, which is great. To help achieve that in Northumbria, about a year ago, we developed an ICE pathway referral. And the aim of that is we spoke to GPs about that and we said, what are the limitations of referring to pulmonary rehab? And it was similar things to what you'd expect. So it was a bit more time consuming, etc. So hopefully with the ICE pathway referral, we are finding it pretty easy to refer and certainly less time consuming than the previous way of doing it. We also, again, try and improve patient knowledge, but also kind of GP knowledge as well, is we've created a pulmonary rehab information letter. Now, this is to be given to the patients at the time of referral. So if we are in a GP practice and we've got a patient coming in for the annual review and you've discussed pulmonary rehab with them, it would be a great addition to give them this information letter there so they can go home, have a read through it. The information letter is on the following slide, so I won't describe it in too much detail yet, but it just gives the patients a little bit of a knowledge about what they're being referred to, okay, because we're much more likely to see them coming to us a couple of weeks later if they have a good indication of what they've been referred for and they've had that explained to them. So hopefully it'll just give us more referrals and also patients who are willing to commit to the programme because it's already been discussed with them. Yeah, Laura, if you want to move. So this is just a little screenshot of the ICE referral and how to refer to pulmonary rehab. It's pretty straightforward. I hope everyone's managing to do it okay. If any of our patients have got absolute contraindications such as unstable angina or severe aortic stenosis, the referral on ICE, it won't let you complete the referral. It'll essentially just kick you out because the patient's not appropriate for pulmonary rehab. So hopefully, again, with this, we're getting accurate referrals to us for patients who are appropriate to complete pulmonary rehab. And I think this has definitely helped because I think from my knowledge and certainly from my time here, we are getting busier. We are referring more patients from GPs, so that's great, and keep that going. If we move on, Laura. So I know this is very small on the screen. I know Laura had mentioned there that she's happy to kind of send that out, which would be great. But essentially, this is the information sheet for patients that they would get with you guys, once you've had a chat with them about it, you can give them this information. It basically just describes the pulmonary rehab journey, so what they will be doing when they've been referred. So the first thing they'll do after you've referred them for pulmonary rehab, they come to a clinic in the nearest hospital to where they live, and basically they would be seen by a senior physiotherapist, and they would have a one-to-one appointment where we screen them. So we screen them to see if they're suitable to come in for the exercise program. So at this appointment, we look at things like past medical history, their level of function, so MRCD score and how breathless they are, and then also it gives us a way of just giving them a lot more information about what the program is. If we deem them suitable from that appointment, they would then be booked in for a pre-assessment. Now, the pre-assessment, is where they would do a walking test with us, and they would also go through some questionnaires, and we use those things as outcome measures. So we'll do them before the 6 weeks of exercise. Following that appointment, they would then be enrolled into the actual exercise classes, where they would be with us for 6 weeks. And then after that, they also have a post-assessment where we repeat the 6-minute walk test with them, and we also repeat the questionnaires. And that just allows us to measure how effective our program is, but it also gives the patients an actual like an objective look, if you like, to see, well, actually, I have improved. This has worked for me. All this hard work has paid off. So we're hoping that it would just give them more encouragement and motivation to continue. But that essentially is kind of the aim of what this information letter does. Hopefully all GPs already have it. I know Karen, my manager, has sent it out with the GP communications a couple of times, I believe. But if no one does have it, then like I say, Laura is more than happy to send it out, which would be great. Lovely. Just want to move on, Laura. So referral criteria for pulmonary rehab. So the patients that we kind of want to have within the program. So they normally have to have a chronic respiratory disease. So that could be COPD, interstitial lung disease, bronchiectasis, or asthma. What I will say on that one, we do also have patients who, if they've previously had lung cancer and they've had a lobectomy and they've had post-op breathlessness, we do also include those patients as well within pulmonary rehab. MRCD score. So for COPD patients, we can refer MRCD 2, 3, 4, and 5A if they've got COPD. The reason for that is there's recent studies to say that MRCD 2s with COPD can benefit from pulmonary rehab. For other lung conditions such as ILD, bronchiectasis, and asthma, MRCD scores of 3, 4, and 5A can be enrolled into pulmonary rehab, can be referred to us. We don't feel that pulmonary rehab, is appropriate for MRCD 5B patients, and these are the patients who are unable to get washed and dressed by themselves because they get so breathless with it. Unfortunately for these patients, pulmonary rehab is just going to be too intense for them, and they're not going to be able to manage the exercise intensity that we would require to improve. For those patients though, we can still give them some respiratory support, but it would more around just be how to manage breathlessness, how to clear the chest effectively. We wouldn't be able to prescribe exercise to those patients. So referral criteria would also include those patients following an exacerbation of lung disease who require hospitalisation. They don't always have to be admitted to hospital. If somebody's had a really nasty chest infection and they've required, say, 3 or 4 courses of antibiotics and their functional baseline is significantly altered from what it was, then we would bring those patients in as well. Just while we're talking about this, so what I would say is if patients have completed pulmonary rehab and they've remained stable, we would require them to at least self-manage for 12 months after completion of pulmonary rehab before we would then accept another referral for them. The reason for that is we want them to try and self-manage. That's the whole aim of what pulmonary rehab is. We don't want them to rely on pulmonary rehab. We want it to kind of give them motivation to have positive lifestyle changes, which they can then continue in the community. However, if patients have completed pulmonary rehab and then either, say, 3 months later have a really severe chest infection and get admitted to hospital, or have been to see the GP 3 or 4 times and they're really struggling, then we can accept those patients back within a 3-month period after completion of pulmonary rehab. Okay, so they're kind of the guidelines that we would look at when we're thinking about, if you're not sure what the time has been between the last completed pulmonary rehab to when you want to refer again, send the referral, and then we would always just send you an email reply if we feel like it's not suitable at the moment, but send it through. And obviously patients have got to be motivated and capable of completing pulmonary rehab. Like I say, it is a commitment. It's 2 days a week over 6 weeks. And then we do advise of a 3rd unsupervised session at home. So we need to have patients who are motivated and capable of completing. Yeah, if you want to move on. So just quickly looking at MRCD score. So I know we'll likely all have a knowledge of what this is and the certain grades of MRCD scores, but just as a bit of a refresh, so your MRCD2 patients would be breathless when hurrying or walking up a slight hill. So these are pretty functional patients. MRCD3 patients would be those who walk slower than peers on the level. So they might stop after about 15 minutes at their own pace. That might be the patient who comes in and he says, well, I walk my dogs a couple of times a week. That's probably those patients that we're looking at there. MRCD4. So these patients are breathless after walking approximately 100 yards or after a few minutes on the flat. These are likely the patients who say, well, I managed to do my own shopping, but I get a little bit breathless in between aisles, etc. And then your MRCD5A, so this is kind of the less functional end of the scale. So these patients are too breathless to leave the house, but they are still able to manage the washing and dressing. We do include these patients in pulmonary rehab. I think these patients are the ones who probably need and who probably will benefit from it the most. Okay, so that was just a little refresh on the MRCD. So just moving on to the contraindications of the program. So these are the absolute contraindications. So these are things that if we try and click yes on these contraindications when we're trying to refer, it'll just kick you out the referral and it won't allow you to complete it because they're not appropriate for the program. The majority of these are your unstable kind of cardiac conditions, so unstable angina, severe aortic stenosis, any uncontrolled arrhythmias, so any active myocarditis, pericarditis or endocarditis, uncontrolled heart failure, so when patients are really symptomatic with it, a mental impairment which is causing the inability to cooperate, any acute kind of pulmonary embolisms or thrombosis, severe neurological problems, so this is kind of really dense strokes, for example, and things like that, which severely affect mobility. So anyone who's had a recent myocardial infarction or a heart attack, so they have to wait at least 6 weeks before coming to something like pulmonary rehab. The likelihood is these patients will already have been enrolled into cardiac rehab if they've had that event. And then just other conditions that may preclude exercise. So this could be like if someone's got really severe Parkinson's, for example, and they can't walk to a pace or exercise to a level to get breathless, because actually it's the Parkinson's which is the limiting factor, not the breathlessness. So pain, we would say, is not an automatic contraindication. Obviously, there's a lot of conditions with symptoms of pain. We have a list of alternative exercises or modified exercises that we can use with patients who have got pretty bad pains. I would say if you're on the fence about referring somebody with a painful condition like arthritis or like some kind of cervical spondylitis, for example, all those things, I would suggest just putting the referral through to us. We would then screen them and we would feel like, actually, what is the major limiting factor for this patient? Is it breathlessness? Is it pain? When we're having a chat with patients about pulmonary rehab in GPs, I would always just think about what is the major limiting factor for this patient, because if somebody says, well, I can walk 50 yards, but after 50 yards, my back pain really kicks in and I need to sit down. And then you say, oh, well, do you feel breathless at this point? And they say no. The likelihood is they're not going to be able to exercise to a level to get breathless. So it's just about having that initial conversation with the patient. If patients say, well, actually, it's a bit of both, it's a bit of pain, it's a bit of breathlessness, refer them in, and then we would screen them to see if they're appropriate. So we go, yeah, that's it. So like any service, we have to prove that pulmonary rehab is effective. And the BTS guidelines, again, the gold standard of pulmonary rehab, suggests that we need to prove exercise capacity, dyspnea, and health status. So there are domains that we need to measure. Okay, so dyspnea, exercise capacity first. So we do that by performing a 6-minute walk test. So we'll do that at the pre-assessment, and then we'll do it again at the post-assessment. Dyspnea, we go through a questionnaire with them called the Chronic Respiratory Disease Questionnaire. And again, we repeat that both pre and post. So health status, we do the CRDQ and also a COPD assessment test. And that just gives us a general viewpoint of how they're managing their symptoms. And then we also have a little look at anxiety and depression. And again, that's just because these can be quite prominent when patients have got a lung condition or get breathless. And we measure that using the hospital anxiety and depression scale. So once we've had somebody go through the process of pulmonary rehab and we've done their post-assessment with them, we would then communicate the results to the referral clinician, but we always copy the GP and we always send a copy to the GP. So we should always have the patient's results from the last pulmonary rehab sessions on the systems. Okay, so you should be able to see that information. I want to move on. So this is how we're doing within our trust over the last 12 months, sorry. So I've just put these figures together over the last couple of days. So this is went from kind of March 23 to March 24. So it's pretty up to date. So the first thing I would look at is the blue column at the top. So the 6-minute walk test. So the minimal clinically important difference is to achieve a distance of 54 meters further. So to walk 54 meters further after the 6 weeks of exercise compared with when they came in at the start. So obviously you can see that our number is 81. So we're doing pretty well with our exercise capacity and improving our patients' exercise capacity. With regards to our CAT improvement, which is the health status, again, a small kind of change, a large change would be known as 2 points on the CAT. So if we look at our scores, so we're currently we've improved our patient's CAT on average by about 6 points. So again, it's pretty good. Like we're getting large improvements in health status as well as exercise capacity. And the final one, so dyspnea improvement. So this is done using the CRDQ questionnaire. So a small change in a patient's breathing, a small improvement, would be a score of kind of 0.5. A moderate improvement would be an improvement of 1 point, and then a large improvement would be an improvement of 1.5. So again, we're managing to kind of stay ahead of the curve, if you like, and we're managing to improve our patients' dyspnea by 1.58. So again, we're achieving kind of over that large improvement. So in a nutshell, it just shows that actually pulmonary rehab works for our patients, and the patients that you're referring in do walk further. They do feel like they can do more following the 6 weeks. They feel like they can manage the symptoms a lot better, and they also feel like the breathlessness is improved on a daily basis. So these are all really positive things for the patient, but also our service and the GPs as well. So at the end of the programme, what we'll do is we'll ask patients to fill in kind of a patient satisfaction questionnaire, and that basically just gives the patient their voice to say what was good about the program, what wasn't too good about the program. And we also just have a comment section where patients can write what they want, be it positive or negative feedback. I've just kind of put a couple of quotes here about what patients have been seeing, so I won't necessarily read them out, but I'll just let you have a little look at them. But it just shows that obviously patients do value pulmonary rehab, and they do value the improvements that have been made. One thing as well about pulmonary rehab that we can't kind of measure is just that level of feeling part of a group and that kind of social bonding with other patients who are going through similar things to themselves. There's a lot of times patients can be a little bit sheepish and a little bit quiet when they come to the first session, but actually after kind of 6 weeks with us, they might go, and patients sometimes ask to be referred with other patients in the group to certain services in the community. So they kind of become like exercise buddies, if you like, where we've finished our program, they then go to the next step in the community together. So it's all just about kind of from the patient's point of view as well, just building relationships and feeling part of the team, if you like, when they come to us. So we've spoke a little bit about this previously, but when patients are about halfway through the program, we'll have a chat with them about have they been thinking about what they want to do following the 6 weeks with us, in the sense of do they want to be referred to other services in the community, such as health trainers or exercise on referrals, or Healthy Hearts in North Tyneside, for example. Do they feel at that point, now that they've finished the 6 weeks, they're a bit more knowledgeable, they're a bit fitter, do patients just feel like they want to just independently go to the gym themselves? And for your higher level patients, or maybe your MRCD2s in particular, that's okay. If they feel confident doing that, that's all right. We speak a lot about walk-in groups and walk-in programs with the patients, and we provide them with different documentation and resources about how they can get involved with that. A lot of the patients have enjoyed that social side of it, but they now just think, actually, I just want to crack on with what I've been doing in here in my own kind of home environment. So what we do for these patients, we've either got DVDs with the exercise sessions on, so it'll be a physio on the screen performing the exercises with them. And also within the DVD, sorry, you've got all the education sessions that have been done within the program. And then obviously we've got written programs as well, where we can give them exercise sheets that they can fill in at home going forward. For patients who've really hated that gym-based exercise that they've done with us, but they've maybe just tolerated it because they know they were going to do it well, there's advice and education around how to continue to get your steps in at home, just with doing activities such as hoovering, mowing the lawn, going shopping, DIY, etc. As one of the education sessions, like I say, this is talked about and discussed as a group. So we give them all the information and all the resources, so they've got all that information to make kind of an informed decision about what they want to do going forward. All right. And then with these patients, with regards to the discharge plans, they would then have that written down and communicated to them when they leave, so they'll know exactly what they're going to do to continue being active going forward. So for patients who are unable to attend, so say a patient gets referred to us from a GP, say they've had pretty severe pain, but they think we get breathless and pain limits our function, and we deem them clinically unsuitable. So for these patients, what we would be doing is we wouldn't be giving them a home exercise program, because if we feel patients can't manage to do formal group-based pulmonary rehab, then we don't give home exercise programs or modified home exercise programs anymore. The only patients who would benefit from home exercise programs would be those who just physically can't attend a group. So that could be if patients have got caring commitments at home, or patients work full time and they can't commit to coming twice a week. We'll give them the exact same program. Yes, they might not have a treadmill or an exercise bike, but we'd expect them to still be able to manage the 6 minutes per exercise. So that would be the criteria for your home visit patients. So if you have spoke to someone in clinic and they say, well, I can't commit to that because actually I work twice a week, still refer them through, and then they might end up doing a home exercise program. Okay. The home exercise program, they would still do a 6-minute walk test and the same outcome measures as the group. We would have to go and see them at home just to ensure that the environment is safe for them to do the exercises. And then what they would do is they would basically get a telephone call once a week over 6 weeks to monitor and see how they're doing, try and progress that program if we can, and then they would come in for the post-assessment again. Not as robust, definitely, as a group-based pulmonary rehab, and the evidence around the home programs are a little bit more woolly. Okay. If we go back to your patient who's got a lot of pain and we deem them unsuitable for pulmonary rehab, what we would then do is we can give these patients a separate one-to-one appointment in clinic where we can give very general advice and education about how to manage breathlessness, how to clear phlegm out of the lungs, and also just general how they can get the steps in at home. So it's a lot more vague, if you like, and we don't prescribe exercise for these patients, but they still get that breathlessness management and they still get that chest clearance, etc. management as well. So they would be the two kind of options that we have. But what I would say is if patients can come to a group and they can perform pulmonary rehab in a group-based setting, then that's definitely the best thing that we want. So just to quickly finish on, so what we're trying to do in Northumbria Trust at the moment is we're continuing to expand pulmonary rehab. So Berwick, like I was saying, Berwick, we're hoping to speak to a venue in Berwick kind of imminently within the next 2 weeks or so, and hopefully get a cohort set up at Berwick. We are also looking at different venues across the region, like Ponteland is one where we get a lot of referrals. I can't think of all of them off the top of my head, but there's a few that we're looking into. We've also piloted virtual pulmonary rehab. So this is where there would be a live physio on kind of a Teams call like this, doing the exercise sessions with a group of patients together. That's piloted. It was very successful, but we just need to think about how we can run that out in more of a larger numbers, if you like. And then at the moment, we're going for something called accreditation. Accreditation, in a nutshell, is where our program can kind of stand up to high values that are given by the BTS. Essentially, for us, it's great if we achieve it because we'll get more long-term funding and then we can continue to try and expand. And I think that was about everything. One thing I didn't touch upon there, but I'll quickly just mention because it's fairly important. So for patients who are on oxygen, we can accept patients on oxygen as well. That's not an absolute contraindication. They would have to go to a hospital venue from the safety aspect, but we can still have those patients be referred to us. And again, this is just if we don't feel comfortable referring or we've never referred before, this is just a really kind of step-by-step guide, if you like, how you would refer to pulmonary rehab. But I think the majority of GPs have been referring via ICE now. It certainly seems to be the most popular, which is great. But if we're unsure, this will just give you a little bit of advice on how to do it. So that was kind of everything that I had to discuss. But if anyone's got any questions, I'm happy to answer those or discuss anything with you guys.
That was great. Thank you.
Okay.
I will share the PowerPoint, and I will also share the recording of this. Sorry, I don't know why I've got an echo. But yeah, if no one's got any questions, we'll end it there.
Yeah, and I think just to finish on as well, if anyone feels like they do want to come and observe a pulmonary rehab session, because Laura, I know you came and found it fairly helpful just to see it in really action and see how it is. Yeah. Then I'm happy to be emailed. So I think Laura's got my email address. So
I'll include that as well. Yeah, with all of the information I sent to everyone.
Yeah, so happy for people to come and observe it and see how it works.
It was really, really useful actually, and since having been to the session and then describing the sessions to patients, it's much better to be able to kind of know exactly what they'll be doing because you can better describe it.
Yeah, no, absolutely.
That's lovely. I'll assume nobody's got any questions. So thank you very much for your time, Craig. And please, if anyone needs anything, just get in touch. If anyone would like to see any other sessions like this on any other topics, please just let me know.
Lovely.
Thank you so much. Have a good afternoon, everyone. Bye.
Thank you.
think she's probably gonna, yeah.